Great. So, good morning, everyone. I'm Dr. Munjal Pandya. Today, we are taking another session of hematology back to back. So, that would be the great, obviously, in continuation with first. So, I'm not going much in detail. As the few newcomers are there, this is medical MCQ for all. Very quickly, what we provide and services we provide is this PROMETRIC 1000 MCQ book. It's an excellent book updated in January 24. It contains at least 1000 MCQs with answers and explanation. And we have the ebook as well. So those who wants the ebook, they can get the ebook as well. The same updated books in hard copy form as well as in soft copy form. We do the online subscription and online coaching. The online coaching is the same way what we are doing it now. Every day, Monday to Saturday, and every Sunday, I'm going to take a mock test or some specific subject related mock test. We provide WhatsApp subscription, we provide Oman Viva subscriptions as well as coaching. So probably we are the only player in which giving the formal training for the Oman Viva. So Dr. Madi, who is based at Oman, she's in charge of this Oman Viva. With our other faculties, we are taking it. Data flow is done also from Dubai. So those who are in Dubai, contact Dr. Anjali, who is in Dubai. Dr. Anjali, I will share her number. So any queries regarding data flow, exam booking, documentation, anything related with the data flow or PSV, primary source verification, feel free to call Anjali. She will guide you, and there is a short package as well, especially designed for those students who have second attempt or third attempt or last attempt. They must join the short. So more information I will provide you later on just to save the time. And we have the mobile applications as well. So those who did not download it so far, our mobile application, either on Android phone or Apple or iPhone, there is excellent. They can download it from our website, or you can just drop me message or Pallavi. She will send the link. So this is all my academic credential. I did my fellowship in hematology, oncology, and bone marrow transplantation training from Italy, Rome, one of the reputed institute. And I have more than 15 to 20 years of clinical experience with more than 10 years of teaching experience and treated almost more than 100,000 patients so far. So probably my clinical experience will help you a lot today. This is Dr. Arti, who is a consultant pediatrician taking regular lectures. This is Dr. Maddy, emergency medicine and this internal medicine. Dr. Shikha Garg, she is a consultant gynecologist. The good part about Shikha is now she also cleared the DHS specialist gynecologist and moving to Dubai in the next month. So we are planning to start exclusive classes for specialist gynecologist. So Dr. Shikha will be the in charge in future. Dr. Ankit is a consultant gastroenterologist, so he is also taking all GI lectures and all. So this is our all team. This is the Pallavi. I think everybody knows Pallavi. She is taking regular messages and all blah blah posting in the group. She is a support manager, and we have other IT team and all lot more team. But these are the main clinical teams. These are our number, and this is the hard copy book as I told you. Right, this is front and back page. And excellent things recently we launched that the coaching earlier it little difficult. 40 hours of coaching used to be 500 USD, but with this request we make it almost half. So now everybody can join and they get the benefit of coaching, because it is, once you are in coaching, almost there are 95% chances that you may crack the exam in first go, because it's the concept based, not just mugging up or ratifying the thing. So if you know the concept, you can answer anything. And this is the data flow, Dr. Anjali, as I told you. So the all numbers of Anjali is here, right? So I'll share the PowerPoint later on. So you can contact me as well. You can contact Pallavi, anyone you can contact. So we'll guide you. So let's just move and jump to the main core topics today. So get ready, everyone, with the pen and paper, right? We'll discuss properly this all questions frequently asked in exam. Tremendous questions today. Instead of 10, I selected 15 questions, almost cover all the various aspects of hematology. So first questions in front of your screen, right? Be cautious and try to understand. In a patient with raised WBC, RBC and platelet count, which of the following investigation should be performed to confirm a diagnosis of polycythemia rubra vera? Bone marrow. Option A is bone marrow. Option B is LDH. Option C is JAK2 mutation. Option D is a hematocrit, and option E is a cytogenetic. We'll discuss the other questions later on. So in this questions, you read it properly. Now the three things, as I told you earlier, those who are new, just keep in mind, and this triad will extremely help you a lot. Whenever you solve any MCQ, means multiple choice questions, remember this triad. You must know in each MCQ. So say for example, this is MCQ. So what you need to know? You need to know the diagnosis, you need to know investigation, and you need to know management. So in one MCQ, probably you know the three answers. So say for example, every day you are solving 100 MCQ, and if you apply this formula, means you are solving 300 MCQ. So this is smart work. So whenever you come across any MCQ, you try to do investigation, I mean diagnosis, investigation. So we'll go one by one. Diagnosis. So what's the diagnosis? They have given the diagnosis. So our job is bit easy, right? Polycythemia rubra vera or polycythemia vera, in short, right? Now what they are asking? They are asking, right, following investigation. So now they are asking about the investigation. Which investigation, right, is supposed to be the base test which confirms the polycythemia rubra vera? Yes.
JAK2 mutation.
You can post your answer in the chat box as well. Everyone can post the answer in chat box. Right? Try to interact. See, don't worry about right or wrong. Until and unless you interact with me, you will not probably get that idea. So you post the answer. No? We are many peoples in the every time we are 40, 50. Yes. Yes, Dr. Azil. Welcome to the board again.
Good
Start.
morning, sir.
Very good morning. Start now.
Sir, confirmatory diagnosis will be bone marrow is what I think, sir. I'm not sure about it.
Okay. So say for example, we did a bone marrow for this patient. What you are looking for in this patient for bone marrow? You did a bone marrow for this patient. What, how you confirm from the bone marrow that okay, fine, this is polycythemia vera? Do you see something in morphology, in a bone marrow aspirate or bone marrow biopsy or trephine biopsy, that okay, seeing something under microscope, you say, oh sir, this is polycythemia vera, this is essential thrombocytosis, this is chronic myeloid leukemia? So do you see something under microscope? Because bone marrow is what? Bone marrow is a procedure. I have a video. I will share with everyone how to do the bone marrow, right? And what are the indication? It's almost more than 20-30,000 likes. There are a lot of medical students are seeing it. So I request you to see that as well. I'll share in the link. Bone marrow biopsy. So bone marrow biopsy is what? You are taking one sample from the posterior superior iliac spine, and from that posterior superior iliac spine, you stay in it and you see under microscope, as in, are you getting me? Right.
Yes, sir.
So
Yes.
what will you see in the bone marrow? Anyone anyone those who are with the bone marrow, answer bone marrow. What will you see? 1 plus, there is one person who joined as a 1 plus DN2101. So hypercellularity is there. So hypercellularity could be in anything. Dr. Thamim,
RBCs.
right? Dr. Thamim, are you there? So hypercellularity could be there. Hypercellularity seen in the polycythemia vera, hypercellularity seen in myelodysplastic syndrome, it is seen in acute myeloid leukemia. Except aplastic anemia, there are a lot of condition in bone marrow where you see the hypercellularity. Somebody posted hypercellularity. So
Yes,
hypercellularity
sir.
will hypercellularity.
Increase in RBCs, I think.
Yeah, so increased RBC is not a diagnostic point. Na? RBC is already increased. That is what you can see in the peripheral smear. So increased RBC could be in many conditions. You need something specific which is not found in anyone, right? So LDH can be increased in many conditions. Hematocrit may be in many conditions. Cytogenetic is not the diagnostic test; it's a prognostic test. So answer is a JAK2 mutation. Remember, answer is a JAK2 mutation. What is JAK2 mutation? So JAK2 mutation is a test. JAK2 you can do it from the blood. JAK2 you can do it from the bone marrow as well, right? So JAK2, right? JAK2 mutation. So this is the literature. JAK2 V617F mutation, acquired clonal mutation of the hematopoietic cells resulting in JAK2 kinase amplification of cytokine response. JAK2 is present. So see the number, JAK2 present, right? In 90% in polycythemia rubra vera. So highest in polycythemia vera, second highest in myelofibrosis, and third highest in the essential thrombocytosis. Rarely or almost you cannot see in a chronic myeloid leukemia. So if you have heard the myeloproliferative disease, have you heard? Have you heard this, Dr. Azil? Have you heard myeloproliferative disease or not?
Yes.
So,
Yes, sir.
what is basic of myeloproliferative? You don't need to ratify. Myelo means bone marrow. Proliferation means increase the formation, and disease means related with this. So, hemoglobin increase, WBC increase, platelet increase. When it is isolated, sometimes HB increase, polycythemia vera. Usually in CML, WBC is increased. In essential thrombocytosis, more platelet is increased. So, these three conditions are in myeloproliferative. And fourth condition is myelofibrosis, where there is an increase in the fibroblast in the bone marrow, and that causes fibrosis of the bone marrow. So this myelofibrosis and CML, there is a massive splenomegaly. So causes of massive splenomegaly is a all myeloproliferative can do the splenomegaly, but myelofibrosis and CML has a massive. What do you mean by massive? Spleen is usually in left upper quadrant or left hypochondriac region. It comes up to the right iliac fossa. So from left lower chest comes up to the right iliac fossa. So massive all the way trans abdomen. I mean, it travels and huge spleen, very huge spleen, right? So JAK2 is not present in any other condition apart from myeloproliferative disease, especially polycythemia vera. Even some literature say 98%. 98% of the patient present with the JAK2 mutation. So if you have a JAK2 mutation, there is no other diagnosis. It is myeloproliferative disease. That's it. It cannot be seen in a reactive, right? Say some, for example, infection. Some patient has an infection and WBC count goes up to 50,000. Platelet is also increased because of infection. Instead of 150 to 450, it is a 700,000, right? But if you do JAK2 mutation, it will be negative. So JAK2 positive means it is a myeloproliferative disease, right? So that's it. Is that clear, Azil?
Yes,
As
sir.
any
Yes, sir.
confusion? Any
No, sir.
confusion?
No,
Right?
no,
So
no.
bone marrow will not confirmatory. You can get little idea. Bone marrow, what will you see? There is a hypocellular marrow. This is one thing you get from doing bone marrow of this patient. There is an increase in erythroid, myeloid, and megakaryocyte increase. Why? Because this increase will eventually increase in the peripheral blood, right? So this is the information you will get it from the bone marrow, right? If you are suspecting leukemia, you can see the blast. You are not suspecting leukemia because they already had given the diagnosis polycythemia vera. So we are not thinking of leukemia, right? So bone marrow is not there. LDH will not confirm by, right? Because LDH increase in myeloproliferative disease, leukemia, lymphoma, hemolysis, right? B12 deficiency. There are lots of conditions where LDH is increased. So you cannot diagnose only on LDH that, okay, fine. Hematocrit is absolutely not helpful, and cytogenetic is a prognostic test. Prognostic test. It's not diagnostic test for any condition except CML. In CML, you see translocation of 922 that we'll discuss. We discussed a lot last time. Anyway, so JAK2. So did you understand, Azil, that how to exclude the things? You don't need to just give the answer, but you need to exclude as well. Okay, if you do bone marrow, what do you see? If you do LDH and if LDH is increased, what are the differential, right? If you do the hematocrit and cytogenetic, what are the differential? Dr. Rehan, is that clear to you?
Yes, sir.
Wonderful.
Absolutely.
If you have any question, feel free to ask. I would be happy to answer. Great. So this is the one main stem of the questions. Let's go to the second. Now, as you finish these questions, as you started test of the leukemia, initial diagnostic based and prognostic test. So there are four questions they ask in the exam regarding the leukemia, right? So these four questions, right? So any patient you suspect leukemia, any patient in suspecting the leukemia, let me go quickly. Initial test, first test which comes and give you the idea about leukemia is CBC and peripheral smear. So complete blood count and peripheral smear. Complete blood count, probably there is a pancytopenia, and in peripheral smear there is a probably blast or atypical cell. So this is the first number one test. So if they ask what is the initial test for leukemia, then CBC and peripheral smear. So this is one answered. What is the diagnostic test? So diagnostic test is a bone marrow examination. So by doing the bone marrow examination, you can diagnose the thing that, okay, this is acute myeloid leukemia. Why? Because you see the OR rods in the cytoplasm, and OR rods is diagnostic of AML. one second question, third base test or confirmatory test. So when you want to confirm 100% that which is the best test, right? So you by bone marrow examination, you get to know that is AML. But again, AML, there are 7 types, M0 to M7. Last time we discussed M0 to M7. Most common AML is M2, which is seen in 30% cases, and best prognosis is M3, that is called APL M3, acute promyelocytic leukemia. Bit revision of last. So those who did not see in the first lecture attended, go and attend the first lecture. Means last week, 21st of the April. Today is 28th. So confirmatory test is third and prognostic test is the cytogenetic. So this is how you have to answer. Azil, is that clear?
Confirmatory test is for what?
Confirmatory test for leukemia, and that is called flow cytometry
Okay.
or immunophenotyping. Flow cytometry or
Right.
immunophenotyping. So you need to just keep
Mhm.
watch on this. What they ask. Are they asking initial test? Are they asking diagnostic test? Are they asking confirmatory test? Are they asking prognostic test? Prognostic test is a cytogenetic, right?
Right.
Cytogenetic, what chromosomal abnormality, what genetic changes seen, it will decide how the disease will behave down the line. That is called prognosis, right? So say for example, somebody diagnosed blood cancer today or AML today, and patient's relative comes and asks you, sir, how is the prognosis? Have you answered this question in your clinical practice? Yes or no? You must be right, because patient, the main important question for any disease, not just hematology, tuberculosis, hypertension, diabetes, heart attack, they come and ask relative what is the prognosis, how it behave, how risky it is, that is prognosis, right? How long they will live, this is prognosis, right? So this is a cytogenetic is prognostic test. So here the first questions, as I told you, test for leukemia, all I answered. What are the type of MPD, that also I mentioned you 4 types: essential thrombocytosis, polycythemia vera, chronic myeloleukemia, and myelofibrosis. And how to diagnose, right? So main diagnostic test is a JAK2 mutation, except CML. CML, there is a Philadelphia chromosome present 922. That's all. Is that clear, Azil?
Yeah. Yeah.
Yes, sir. It's very clear, sir.
Any confusion?
No, sir.
Wonderful.
Question is that why don't you straight away do this confirmatory test? Why to go here and there?
Means I did not get the question.
Okay, sir. Let's
No,
move.
no. You ask me. We are not in hurry at all. I'm just trying to understand your question.
In fact, these are the guidelines. You can't do anything. You are right.
Yeah, because see, I mean, without doing the ECG, we cannot jump on the angiography. Some patient comes to you with a chest pain and you say, okay, directly go for angiography. It's not a good idea. You need to
Sir,
little,
that makes sense. But for these tests where these serious illnesses are concerned, we should go straight away to confirmation test. I
yeah,
think
but
so.
yeah, that's correct. But confirmation is done on the basis of suspicious. First, you need to make a differential diagnosis and then you
Okay.
do. Right, if the patient
Okay.
has infection, right, and it's a costly test, so it's not good idea you can spend the good amount of money without so if you have one base that okay, WBC RBC platelets are high, patient has a splenomegaly, right, he is fitting into the polycythemia vera,
Yeah.
then you directly jump to JAK2, right? But
Yeah.
without CBC you cannot jump to JAK2. You understand?
Yeah.
Without
Yeah.
CBC you cannot jump to that okay, fine, I want to do only JAK2, I will not do anything else. It's not a good idea, right? So
Yeah.
that's it. So this is what the thing is. So this is the again literature, as I told you, JAK2, right? So JAK2 is this the JAK2 literature. So 2005 article, separate group independently JAK2 mutation, right? Study shows incidence of JAK2 mutation in MPN. MPN means myeloproliferative disease or myeloproliferative neoplasm. Both are the same thing. MPD or MPN, both are the same thing. So some literature say MPN, myeloproliferative neoplasm, or myeloproliferative disease. Both are same thing. So polycythemia, see here, I told you some literature, 99% of the patient. So it is one of the most sensitive and specific tests is a JAK2 for polycythemia, 60% in ET, 40% in NCML, almost less than 1%, or most of the patient what I treated in last 15 years, they are all negative of JAK2. I'm talking about CML. So CML, it's negative. So myeloproliferative disease, they are positive. So whenever you come across any myeloproliferative disease, think of JAK2. That's it. That is what my take home message. Let's jump to the next question. Number 2, a 45-year-old woman with the, you just check your score. I mean, what the score you had and what's the my score there, right? So you match the answer, what you answered and what is the real answer. So end of the day, you can get the score. And if it is less than 50, it's not good idea. So you still need to push yourself a bit hard for exam. A 45-year-old woman with a diagnosis of BCR-ABL positive chronic myeloid leukemia attends the clinic. She has been taking imatinib for 2 years. Her blood counts is normal and she is well. Which one of the following is the most important investigation in her ongoing management, right? So one of the investigations, so diagnosis again, never ever miss the triad, never ever miss the triad. So you every time just remember triad before answering anything. Do you know the diagnosis? Yes. Do you know the investigation? And do you know the treatment? So here they have given both the things. They have mentioned that chronic myeloid leukemia. So diagnosis is done, chronic myeloid leukemia. Treatment, they have given treatment. He is taking the treatment, imatinib drug. Now what they are asking, the remaining investigation, or which of the following is the most important investigation in her ongoing treatment. So which investigation is most important during her follow-up or ongoing treatment? Bone marrow examination, BCR-ABL in the blood, measure the plasma imatinib level, neutrophil alkaline phosphate score, or blood BCR-ABL. You can post your answer in the chat box. Dr. Ishwarya Joshi, can you little bit throw a light on your answer, bone marrow examination to confirm remission status?
Hi, sir. Can you hear me?
Yes, yes, very well, doctor. Thank you very much for your kind reply. Just a
Thank you, sir.
discussion platform, so don't worry. Whatever is your thought process, you will going to improve a lot at the end of the session. So what do you think? I mean, what you understand in this question, or what is the understanding of you in last two line, especially last two line is this line, her blood counts is normal now, she is well. Which
Yes.
one of the following is the most important investigation in her ongoing management? Now tell me.
Right. So they want to know whether the lady has achieved remission or not. So here the mutations will never change. So the options B and E are excluded.
Sorry,
Then
sorry. Why it's excluded? Sorry.
because the mutations, the mutations becoming normal in the cell
Okay.
is remote.
Okay.
Apart from that, measuring the imatinib level is of no use because it doesn't seem like she has any infection or adverse effects of
Okay.
imatinib.
So measurement of imatinib, I'll remove it, right? By the exclusion. So there is no logic doing the measurement of imatinib and nobody is doing across the globe. Everybody is measuring the CBC blood count, right? If it is a normal, then we feel that it is a normal. So blood counts are here also normal, right?
Yes,
On imatinib, 2 years. So this patient looks to be in the remission. But now
yes,
this patient for ongoing, after 2 years, every 3 months, 6 months, we tell the patient to come for follow-up just to
yes.
make sure that she is in remission. So every time we are going to do Dr. Aishwarya the bone marrow examination to confirm the remission status.
We'll not do every time, but at the point when we think that now that the chemo can be tapered or stopped, we may want to see the proliferation status of the marrow. That is my understanding.
Okay. So have you ever seen the CML patients or any treated any CML patient in your
Yes,
clinic?
I do see CML patients, but
Okay.
not, of course, not under me.
Fair enough. So, I mean, just don't take it otherwise. You are a physician or what?
Yes, I am internal medicine specialist.
Okay, excellent. Wonderful. Internal medicine specialist. Wonderful. Wonderful. Okay, any other comment? What is this neutrophil alkaline phosphate score, doctor? Aishwarya, let this discuss this question with you. So, do you know what is a neutrophil alkaline phosphate or another name is leukocyte alkaline phosphate? Have you heard of these things?
Yes, this is the lab score.
Okay, so lab score is
The lab
increased or
score.
decreased in the CML?
Definitely, it is decreased.
Definitely it is decreased. So your answer is perfect, right?
Yes.
In infections, right, where it is
It is a
increased,
component
but
of a normal cell. In
yeah,
malignancy, this is not going to be present.
yeah, because malignant cells, they are immature cell, and immature cell will not stain with this enzyme. This is enzyme, leukocyte alkaline phosphatase, right? So this enzyme, when you stain with this in CML, right, this is a very, very low, score is low, because whatever the neutrophils are there, it's immature, and this will react with the mature neutrophil. So infection, it's a mature, inflammation mature, right? Reactive mature, DIC mature, septicemia mature, right? So in this condition, lab score is increased, but in CML it decreased, right? So, and this, I remove this as well, right? These two options are gone. Search for BCR able mutation in the blood. So we are not routinely this BCR mutation in the blood regularly, because this patient is in a follow-up, is in remission. So the answer, doctor, is a blood PCR for BCR able. Let me tell you the tree. Let me get it. Just ask me, huh, Dr. Ishwarya, if you are not agreed with me. So
Yes, sir.
CML, what happens? I usually give a tree, this tree example to the residents, right? There are 3 layers, and these are the roots. So what you can first see in first is a CBC, second is a cytogenetic, and third is a BCR-able. So BCR-able is a root. It is the molecular test, right? BCR-able. Cytogenetic is translocation of 922, what you see in CML, right? So when patient present to you first time with HB of 11, WBC count of 25,000, and platelet of 170,000. So patient's WBC is high. You did a bone marrow, you did a PH chromosome, you confirm, right? PH chromosome positive. You also did BCR-ABL, it is also positive. You confirm the diagnosis of CML. You started on the imatinib. After 2 years, patient is fine. This hemoglobin is now 11 to it becomes 12. 25,000 becomes 5,000, and platelet becomes 200,000. So CBC become normal. Is that clear to you? Yes or no?
Yes.
Right? So now after CBC, so this is called as a hematological response. If you have go through the literature and you have treated the patient, so this is called, first is a hematological response, right? It ideally achieves in 3 months. If somebody is not getting the hematological response in 3 months, splenomegaly is not normal, means something wrong. Within 6 to 9 months, you will get a cytogenetic response. What does it mean? Complete cytogenetic response. This is a book term. What happens after 6 to 9 months? First time we do a bone marrow and we look at what happens to this BCR able gene, or sorry, what happens to cytogenetic, and this cytogenetics become normal, like you and me. Absolutely, there is no Philadelphia chromosome within 6 to 9 months of treatment with imatinib. And what is a BCR able? After 12 to 18 months, this BCR able is also negative, which is supposed to be 100% here at the time of diagnosis. So this is called as a complete molecular response. This is how we monitor patients clinically. So what we do in a follow-up, every time we do the CBC and we do the BCR ABL. Cytogenetic we not do. We are not doing any bone marrow in ongoing treatment of the patient. When we do that, I'll tell you. When the BCR able, say for example, this BCR able at the time of diagnosis 2020, 13, 23, right? It is 100% BCR-able. In 2024, same time it is a 0%. It's in remission. What happens? In mid of the 24, it is 10%. End of the 24, it is 20%. And in 2025, it is a 40%. It's rising. Means I'm worried why the CML is rising, why BCRL ABL is rising, means CML is progressing. At that time, I will do the bone marrow biopsy. I will confirm it. I will look for the mutation again in the BCR ABL, and I will look for another cytogenetic abnormality, additional chromosomal abnormalities, right? So at that point of time, the bone marrow aspirate and biopsy is required. Otherwise, it is not required in a routine follow-up. You can do 2 times bone marrow biopsy, usually in a clinical practice. One at the time of the diagnosis you do, and after 6 to 9 months, you do the bone marrow biopsy to confirm that it is absolutely in a complete cytogenetic response, right? This is how you can do. Otherwise, routinely, I have a few patients in last 15-20 years of my practice in hematology, where few patients are I'm following for 10 years, more than 10 years. The blood absolutely normal. They are living normal life, right? They are enjoying, they are getting married, they have kids, normal, everything fine. So we have 2-3 patients like this. We have plenty full of CML, but these 2-3 are more than 10 years. So you can understand completely change the prognosis by coming this drug in the market somewhere 20 years back in 2001 or 2. So imatinib is the first drug, is the magic bullet in the times of article in US. So it's a long story, but I'm not going in much detail. So imatinib is the first targeted therapy which target BCR-ABL oncogene. It blocks the gene and it controls completely the process and pathophysiology of CML. That's it. So this is how it's done. Now open for question. Dr. Ishwari, any question?
Convinced, sir. Right.
You got it?
Yes.
Right. So this is how. So again, we go back to the questions. What they are asking. They are what they were asking that the which one of the following is the most important investigation in her ongoing management. So ongoing management BCR-ABL, that is also done from the blood, from the peripheral smear. So every time, every 3 monthly, we are monitoring the quantitative PCR or other name of the test is real-time RQ-PCR. Have you heard of it, right? Or RT-PCR, right? So RT-PCR for BCR-ABL, we do every 3 to 6 monthly. We try to monitor. If it is in remission, we are not going to do any bone marrow, all right, until and unless there is a relapse. Fair enough?
Yeah.
Great. Any questions? Azil?
No, sir. It's clear. It's very clear, sir.
Wonderful. So we switch to the next questions. Get concentrated. All the questions are different. So switch your gear from myeloproliferative disease to CML to now other entity. So forget about the both things. 62 years old woman is admitted for her total hip replacement. She feels well and currently takes the indapamide for hypertension, but no other medications. The surgeons do not document any abnormal clinical finding, but on investigation, what they found, HB12, WBC 22,500 per cubic millimeter, lymphocyte is 19,000, platelet is 150,000, ECG is normal sinus rhythm. This all pre-operatively. Q wave is slightly inferior. Q wave, chest X-ray is showing LVH, left ventricular hypertrophy, but nothing else of note. Otherwise fine. Ejection fraction is normal. Which of the following is the most appropriate way to manage her or this patient? So you have a one patient who has a total knee replacement posted, did some pre-op workup shows this. Which of the following is most appropriate way for this patient to manage? Cancel her surgery, go ahead with surgery but keep her under hematological follow-up, start LM2 start chlorambucil and start fludarabine. So again, think 5, 10 seconds, 15 seconds, nothing hurry, don't give answer in hurry, always think of this triad. So you need to know what is the diagnosis, which is not given in this scenario, then you can jump on the investigation and then you can jump on the treatment. So first of all, anybody can tell me the diagnosis.
Hip
Sir, it is
replacement.
CLL.
Sorry?
CLL.
CLL. Who's the chap? I mean,
Dr.
who?
Preeti, sir.
Doctor?
Preeti.
Dr. Preeti. Okay, fine. So let's discuss these questions with you. So first of all, the diagnosis by you is a CLL. Okay. So now tell me what points favoring in this scenario, which confirms that this is likely CLL, basically.
WBC is more than 20,000 and age is 62 years first, and WBC lymphocytes is 19,000.
Okay.
Because 80 to 98% lymphocytes will increase in CLL.
So how much is the lymphocyte count? More than how much number, right? You can say that, okay, this is looks like a CLL. Is there any criteria?
I'm not sure about the criteria, so because as I know, it's like 5%. Sorry, it's like 98% of 80 to 90% it will increase in lymphocytes.
Okay, so it is not
But
based.
according to me, it's very
Fine.
high.
Fine, it's very high. So your diagnosis is basically CLL because it is a lymphocytic leukocytosis. That is why.
Yes, sir.
Okay, fine, fair enough. So let's discuss. Dr. Bahar Toprak, why you answered the chlorambucil? What is chlorambucil? Dr. Toprak. It's
Yeah,
important.
I'm
This.
here, but I don't know what is the chlorophyll.
So what will you do? It's a simple question. That 62 years lady come to you with a hip replacement. She is fine, clinically fine. Surgeon didn't found any documented abnormalities, but on CBC she found to have two things. What we can say, for example, evaluate what is wrong with this patient. Say for example, so one is a WCC, means white cell count. It is supposed to be 4,000 to 10,000, right? If I am not wrong, is that correct? Per cubic meter. So instead of 10, it is 22, right? And lymphocyte is usually less than 1500 normally, right? And definition is more than 500 absolute lymphocyte count. More than 500, 5,000 for more than 6 months is called as likely CLL. So this is 19,000 instead of 5,000, it's 19,000. So something wrong in WBC, something wrong in the lymphocyte. So something with the chronic lymphoblastic leukemia. This is the classical presentation. So elderly male or female presented with something else and they end up with something else. So CLL patient usually, right, they find incidentally. Have you heard the term incidental? Means they are going for some pre-employment checkup and they found to have CLL. They gone for appendix operation and they found CLL. They went to US before immigration. They did some blood test and they found to have lymphocytosis. This is CLL. This is classical presentation of CLL, book picture CLL, right? So classically CLL. So now, Toprak, what do you want to do with this patient? Now, this is a suspected. This is suspected. You did not confirm it. See, there are 4 tests: initial test for any leukemia, confirmatory test for any leukemia, right? Sorry, second is diagnostic test for leukemia, confirmatory test for leukemia, and prognostic test. Let's discuss this CLL. So this is suspected CLS. High possibility that this patient has a CLL. So initial test you do CBC and peripheral smear. You did it already, right? Now diagnostic test, you may go for bone marrow biopsy. And in bone marrow biopsy, what you see is a multiple hypercellular marrow. You see increased number of lymphocyte, usually more than 90% of all mature looking lymphocyte, right? And confirmatory test is a flow cytometry, as I told you. So you see a flow cytometry confirmation, right? It is a CLL, and prognostic test is again a cytogenic. What I explained you already in first this Jack 2 wala this discussion, right? So this is how it works, right? So this patient is likely CLL. So are you going to cancel the surgery, Dr. Bahar Toprak? Are you going to cancel the surgery for this patient? Dr. Sarin, Dr. Somi, Dr. Naresh, Dr. Onkar, anyone, Dr. Dilakshi?
Sir, can I try?
May I
Yeah.
comment?
Everyone can try, my sister. Don't worry. This is the open platform. This is not a specific. I'm telling you the name, right? You are not interacting. That is why I'm giving your name. So interact, na? Everybody is open. Yes, tell me.
Uh,
Try to apply your brain. What it is trying to say. Na? It's not a complicated
sir,
scenario.
62-year-old.
1 minute. Do it one by one, so at least I can understand. Everybody
okay,
together, I can. Yes, you go ahead,
sir,
doctor.
only the WBC has been increased. We don't want just like stage 0, so we don't want to give any treatment. When the lymph nodes are increased, it's also stage 1. We don't want any treatment with this patient because this patient is in incidentally found with this, and
Okay.
he don't have anemia.
Okay, great. Wonderful. You don't have
And
anemia, even you don't have a thrombocytopenia. 150 is a
yes,
normal, na? Lower normal, but it's normal,
yes, sir.
right?
And yeah, because anemia stage 3, where we give the drug fludarabine, it is like a purine analog. We don't want to give that, and
Right.
so option D is excluded, option E is excluded, and D, I don't know what is that. And option C, when the fludarabine is fails, only we'll give altimazumab, that is monoclonal antibody. The C also gone excluded. And we don't want to cancel the surgery for this patient because she's on stage 2 or 1 only. So we can give go ahead with the surgery.
Wonderful. Excellent. Brilliant. Wonderful. So this is what the explanation. I will make it more even simplified. So what she explained is absolutely correct. That is completely correct. So this is a suspected case of CLL, right? CLL, chronic lymphoblastic leukemia, right? Now he's posted for surgery. So you need to do something for surgery. If it is anemia, if it is thrombocytopenia, if it is a clinically very bad lymphadenopathy, huge hepatosplenomegaly, then you probably cancel the surgery, try to fix up the another problem which detected incidentally. But this patient is fine. This patient has well. This patient feels well. There is a no problem to the patient. It's incidentally she went for the hip surgery and she found to have on pre-op investigation this, right? So you don't need to postpone the surgery. What you can do, you finish it off the surgery as patient is fine. There are 5 stages: stage 0, stage 1, stage 2, stage 3, and stage 4. Let me first go to the stage as well, just to make you better understand, right? These are the stage of the CLL, chronic lymphoblastic leukemia. There are few stages which you must know. This is another question in exam. So stage 0 is what? There is just only lymphocytosis alone. So this patient has just lymphocytosis alone. So by me, it's a stage 0. When there is a lymphocytosis plus lymphadenopathy, it is stage 1. When there is a lymphocytosis is everywhere, that is a primary criteria. Lymphocytosis is everywhere. So here only just lymphocytosis. Here lymphocytosis plus lymphadenopathy. Here lymphocytosis plus hepatosplenomegaly. Here lymphocytosis plus anemia. Definition of anemia is less than 11 HB, right? Here 12 HB. So it is not a stage 3. It's not a stage 3, right? There is a thrombocytopenia less than 100,000. This patient has 150,000. So it is not stage 4. They do not have hepatosplenomegaly. They do not have lymphadenopathy mentioned. So stage 0, low risk patient, absolutely low risk patient, and lower the risk, higher the survival. So they live more than 10 years, 15 years. And let me tell you, I treated hundreds of CLL patients so far. So CLL patient many a times they die because of heart attack, not because of leukemia. Is that clear? Because this is a disease of elderly, usually 60, 65 plus. So either they die because of diabetes, kidney failure, liver failure, heart attack, stroke, right? So it is a very, very slow growing condition, especially stage 0 and 1. So you don't need to disturb. Another question in exam, which classification? Doctor, do you know the classification? The name of the classification, who has given this? Have you heard of the name of classification? Rye classification. So Rye classifications, it is called Rye is the name of the person, right? Rye is the name of the person, right? Don't get confused yourself. So Rye is the person who just nominate this classification. So on his name, the name comes is a Rye classification. So what is the same thing? Lymphocytosis 0, lymphocytosis plus lymphadenopathy 1. If you add a hepatosplenomegaly 2, if you add anemia 3, and if you add thrombocytosis, lymphocytosis is common for all. Absolutely. Is that clear to everyone? Yes or no? Yes or no? At least reply
Yes,
me
yes.
yes or no.
Yes,
Yes,
sir.
sir.
Yes, sir.
Wonderful. So
Yes, sir.
let's go back to the
Yes, sir.
question. So in question, nothing complicated, right? This is nothing complicated. So there is a no anemia, right? So no anemia means stage 3 is not there, right? There is no thrombocytopenia. Stage 4 is not there. There is nowhere they mention there is a lymphadenopathy. So no lymphadenopathy, no hepatosplenomegaly. So no stage 2 there, no stage 3 there, 1 there. So this is stage 0 CLL, likely stage 0 CLL by Rye stage classification. It is absolutely asymptomatic, fine, no problem. You go with the surgery, you finish the surgery and keep this patient under hematological follow-up, probably every 3 monthly. If the CLL it gets worsening, in that case you do the treatment stage 0. And let me tell you the one more thing, the same picture you better understand. So stage 0 and 1, right? Stage 0 and 1, this is stage 0 and 1, usually no treatment required. Stage 2, if it is a right stage 2, if it is a symptomatic and patient deteriorating, treat, otherwise no treatment required. Treatment usually comes when stage 3 or stage 4 is there. So this patient is stage 3, stage 0. So even after doing the surgery, you don't need any treatment for CLL. Just keep under observation 3 months, right? Probably from stage 0 to stage 2 or 3, it may goes 5 years. You never know, right? Just keep under surveillance. Treating early in this disease will make more harm than benefit. to a CLL patient. So don't be in a hurry, don't be a panic to treat, especially the CLL patient when they are asymptomatic and stage 0 and 1. That's all. Any question? Dr. Aishwarya, are you getting me?
Yes,
So,
absolutely.
Any doubt, confusion?
I was wondering that this could be an infection and we should evaluate further, but the scenario clearly says that she is feeling well.
Yeah,
So,
so well means there is no fever, no other toxicity in peripheral smear. There is a no toxic granules,
right.
and there is a this type of lymphocyte is very rarely seen in a infection, right?
Yes,
19,000. So
yes,
it's pretty much high. And if there could be infection, there must be some vital instability, tachycardia, fever, blah blah, right? So nothing is there.
yes,
Is that clear?
yeah.
Wonderful. Any question?
sir, what is
Any
the treatment for the other stages of
stage?
CLL?
Yeah, CLL other stages, these are the treatment. We usually we start when we start the treatment, we start depends on patient's context and comorbidities, right? If the patient is young and fit, we start with the fludarabine, FCR, fludarabine cyclophosphamide rituximab. This is the best combination, right? Fludarabine cyclophosphamide rituximab. So fludarabine is the treatment. Elderly patients, mild disease, lot of comorbidities. We start with chlorambucil plus prednisone, steroid, prednisone, and this alemtuzumab is the anti-CD52 antibodies, right? So this is a good drug, right? So it blocks this drug and it stops the progression of CLL, right? Imatinib stop the progression of CML. Alemtuzumab, same, it blocks this CD52 on the surface of lymphocyte, the CD52. This blocks, alemtuzumab blocks this, so it stops the proliferation and it stops the progression of CLL. CLL is like a diabetes, absolutely in diabetes, sugar increase, in CLL, lymphocyte increase. Both are incurable condition, right? CLL is only curable, only cure across the globe for CLL is bone marrow transplant. You cannot treat, you cannot cure the CLL. You can keep under control CLL by giving lifelong all the medicine and more 10 medicines which is given in the book. So all will keep control like diabetes. If you take the diabetes, OHA on anti oral hypoglycemic agent, your sugar is controlled. Once you stop for 1 2 months, again it go up to 200. Same thing, you stop the drug, lymphocyte go to 90%. That's it. So lifelong you have to treat both the condition. Is that clear?
Yes, sir.
Hopefully someone who asked me the treatment part, uh, she got the answer, isn't it? Yes or no?
Yes, sir. Yes, sir.
Wonderful. Sumi, great, wonderful. So going well, we are going well so far, so good.
Yes, sir.
Yes, sir.
Wonderful. Fourth question, easy for you. So don't get worried about long scenario. It's very lollipop question. You just need to concentrate on the specific things. 60 years old man present with the lethargy, nausea, back pain. He has a previous history of hypertension. He is taking Ramipril 10 milligram daily. Symptoms of prostatism for which he takes finasteride. On examination, BP is 142/78. He has a mild spondylolysis and tenderness over his lumbar. Investigation so HB 10.2, WBC 8,100, platelet 132,000, IgG 22.1, normal range is given. IgA 0.5, normal range is given. IgM 0.8, normal range is given. ESR is 61, which looks to be high. Sodium is 135, looks to be normal range. Potassium 4.9, which is up to 5.5 is a normal, so looks to be in a normal range. Creatinine is 167, range is not given, but by me it's little mildly high. Albumin is 25, which is little low. Calcium is 2.8, which looks to be high as per the range, and PSA is 4. Which of the following is the most likely diagnosis? So again, my triad will come. So before jumping to the questions, first do the diagnosis, and they are just asking the diagnosis. So on this clinical vignity, what is the diagnosis? Then you tell me investigation as well, and somebody tell me the treatment as well. So now they are asking in this scenario, what is the diagnosis? This is the clinical picture, laboratory pictures, every pictures, hyperthyroidism, prostatic carcinoma, monoclonal gammopathy of a non-significance. The short name is MGUS. MGUS, you must have heard. Have you heard MGUS? Yes or no? Yes or no? Monoclonal gammopathy of uncertain or unknown significance, multiple myeloma, and Waldenstrom macroglobinuria. Let me check first. What's the comment? Dr. Gressel, any idea? Dr. Gressel. Dr. Gressel, any idea? I want you to speak. Just wait 1 second. Huh? I'm getting called. 1 second. Think over it. Dr. Aishwarya Joshi, any comment? No comment. Yes. Anyone? Toprak?
Yes, sir. If his immunoglobulin G and A is high level and little bit
G
calcium,
and A high?
immunoglobulin G
A
and
is little low. A is little low, doctor. IgA is 0.5 and range is 0.824. So IgA is little low. IgG is high.
Yep, IgG is high.
You understand? It's simple, na? 0.824. This patient has 0.5. So it's little low, not high. IgA is not high. It's little
Okay.
low. But IgG is absolutely high. Instead of 14.5 upper normal, it's 22.
Immunoglobulin M is low. Is I rule out Vanderstone macroglobulinemia.
So your answer is Waldenstrom macroglobinemia, right?
Yeah, I rule out.
Okay. So why did you answer then myeloma or MGUS?
And calcium a little bit high. I
Your
think it is
answer is
multiple.
different on the chat
And
box.
is commonly what? No, my answer is multiple myeloma because is commonly bone disturbed.
So what's your answer? Myeloma or Waldenstrom?
Myeloma.
Let's see. Yes, Dr. Abdul Ghaffar, if you want to comment, you can comment. You raise the hand. You comment. Don't avoid any questions. This same question will come in exam. So you have to answer something. Right? Right or wrong, you have to answer.
Multiple myeloma, sir.
Multiple myeloma. So what point favors? Who is this?
IgG, Dr. Preeti, sir, because
Yes.
60 years and lethargy, nausea, and lower back pain. And already she's on the finance, he is on finasteride. The finasteride I'm not sure with, but IgG level is 22.1, which is very high because in multiple myeloma, sometimes IgG or IgA you will get high, sir. IgG 60% can be high or IgA 25% can be high, and then she's having hypercalcemia. He's having, sorry, he's having hypercalcemia.
So you are going on an absolute right track. So tell me, what are the positive point which makes you to think about multiple myeloma in this patient starts from the first line or age?
First line is age, sir, 60 years,
I
and
can tell you, I
logoplasty.
can tell you 10 positive points of myeloma. So answer is myeloma, but I don't want you to mug up the answer myeloma or anyone. I mean, I want everyone to understand why it is myeloma. So if you cultivate the art of reading the MCQ, that is the biggest plus point for you to crack any MCQ or exam, right? So there are hundreds of plus point, but we never thought. So let me tell you quickly, right? Your answer is perfect. You are going well. So number one, age. It is a disease of old age. So usually seen in 60. So 1 point, it's in favoring myeloma. Second thing is lethargy, nausea, and back pain. So lethargy and nausea is probably because of hypercalcemia. And third thing is a constipation, and hypercalcemia is not under control. Patient may have confusion and eventually coma. So this is a classical 3C: constipation, confusion, coma, hypercalcemia. Confusion, right? Confusion, constipation, coma is hypercalcemia. It's a classical. Go and read it, right? So hypercalcemia is there. This is the symptom. So this symptoms again favoring the hypercalcemia because we are not concentrating on small symptoms. 90% of the patient, this is second point. This is third point. 90% plus patient present of multiple myeloma. Elderly male presented with the back pain, especially the back pain. It is a disease of spine and pelvis. So they present with the back pain. And let me tell you, some patient presents to me with the spine fracture as well, not just the brain, pathological fracture of spine. So this is a presentation. Because of prostatism, you can see little prostate PSA is high. Any infection or inflammation in prostate, it will increase the enzyme or hormone PSA. So this is because of, so don't get confused between prostatic carcinoma, because people are saying, oh, prostate is mildly high, it's a prostate carcinoma. It's not prostate. Why prostate carcinoma will have a nausea? Why prostate carcinoma will back pain? Why prostate carcinoma will have high IgG? IgG is, why should be high in prostate carcinoma? Never, right? So this is a third point, right? He has a mild anemia, 4 symptoms. Most important presentation. Go and read any book, multiple myeloma lecture. First line, elderly male or female, back pain and anemia presentation, backache and anemia. So both are there, right? I treated almost hundreds of patients of myeloma, and we did hundreds of bone marrow transplant, autologous stem cell for myeloma. So I'm sharing my general feel. WBC is normal, platelets are mildly low, right? Not much important, but anemia is more important. IgG is very high in this patient. And when the IgG is high, probably IgA and IgM may be normal or low, right? So, and ESR is absolutely high. Have you heard of one formation, Role formation? Role formation, yes or no? Role formation, yes or no? Tell me yes or no.
Yes.
Yes, sir. Yes, sir.
Wonderful. So Role formation is seen classical in peripheral smear and ESR is high, right? Rest of the electrolyte is okay. Creatinine is also high. Number fifth or sixth. Calcium is high. Number 7. What else you need for the diagnosis of myeloma? You have plenty full of things in the scenario only. I'm showing you, no? This is what you observe. This I observed. I tell you. Now you think, oh no, sir, it is very clear now. Very clear. Why? Because you never, I mean, build a sight of seeing something. Even if you don't read, na, even if somebody doesn't give me the ABCD, na, just by this I can tell, okay, this is myeloma. Khalas. Whatever the differential, I don't want to see. Now let me exclude hyperparathyroidism. Hyper means high and parathyroid, so prothormone increase prothormone means increase calcium. But this hyperparathyroidism does not increase creatinine. It does not create increase in the IgA level, right? It does not usually present with the backache, and it does not cause the anemia. So hyperparathyroidism is gone. Dr. Ishwarya Joshi, stop me if you are not agreed.
Sir, agree. Absolutely agree.
Prostatic carcinoma, there is nothing looks to be prostatic carcinoma, and even not 4. If the prostate is 40, it is not prostatic carcinoma, right? Increase PHA, increase PSA, let me tell you, these are multiple questions in one question I'm trying to solve. So if you have increased, because prostate is very common, so increased PSA, there are condition called as a benign, which is not malignant, and one is a cancer or malignant. So malignant condition is obviously CA prostate, right, when there is an increase, but there are long list of increased prostate in benign or non-malignant or simple condition. First is benign prostatic hyperplasia, second is a prostatitis, third is after doing the biopsy of the prostate will increase, vigorous exercise, vigorous exercise, anal sex, manipulation of prostate by doing the digital rectal examination. This all condition where PSA increase. So PSA increase more in benign than malignant. But what the same time we don't want to miss is a malignancy. That is why our brain is activated in malignancy, malignancy, malignancy. But you need to keep in mind what are the other condition where PSA increase. So these are the condition where PSA is increased, right? And the best test is a biopsy. So here nothing mentioned about the biopsy, so it is not the things. And anyway, in prostate, again prostate carcinoma, you cannot see prostate carcinoma, it goes to bone, and bone can cause, usually the hypercalcemia can cause, increased PSA can cause, but it does not cause IgA elevation. Prostate carcinoma, you cannot see IgA. So prostatic carcinoma is also gone from my side. Monoclonal gammopathy of uncertain significance, it's a benign condition, right? So I will discuss in this same questions later on. Waldenstrom macroglobinuria, what increase is IgM, which is not increasing. So IgM, if it is increased, it is more this Waldenstrom macroglobinemia, right? Means immunoglobulin M is thin and there is a hyperviscosity syndrome. Hyperviscosity syndrome because molecular weight of IgM is very high, and patient may present with the stroke, patient may present with the pulmonary embolism, patient may present with the deep vein thrombosis or hyperviscosity, commonly seen in Waldenstrom macroglobinemia, right? So here IgM is not increased. If you can see in the scenario, right, IgM is absolutely normal. IgM is 0.8, 0.5 to 2. It's normal. So it's not Waldenstrom as well. And it's not monoclonal. Classical case of multiple myeloma. Dr. Ishwarya, any comment?
So perfect.
Sorry?
All clear.
Excellent. Anyone? Anyone in the house? Any comment or questions or confusion? So if you are not asking questions, means I thought that it's all clear. That's okay. Fair enough. Right. So this is what the thing is. Right. So just keep in mind multiple myeloma. I have a lot of literature of multiple myeloma. My favorite topic. Another question they frequently asked in the exam. What are the diagnostic criteria of multiple myeloma? Diagnostic criteria. So there are two criteria. One criteria is called as a major criteria, and another, let me tell in that way, one is a major criteria and another is a minor criteria. So major criteria is what? Anything more than 10% of monoclonal plasma cell in bone marrow is a multiple myeloma. That's it. More than 10%. Don't get confused. In leukemia, how much is the blast? More than 20%, not 10%. More than 20% blast in bone marrow is diagnostic of acute leukemia. More than 10% of monoclonal plasma cell in bone marrow is diagnostic major criteria for myeloma. Is that clear? Yes or no? Tell me at least yes or no. Yes
Yes.
or
Yes,
no?
sir.
Wonderful, wonderful, wonderful. So this is more than 10% bone marrow plasma cell. So they have given clonal or monoclonal bone marrow plasma cell more than 10% is a multiple myeloma. Then what are the minor criteria? Four things. Remember CRAB. Have you heard of CRAB? Dr. Aishwarya, have you heard of CRAB?
Yes, yes.
Right. So
Yes.
C stands for calcium or hypercalcemia. So calcium should be high, which is there in our scenario. Renal insufficiency means EGFR getting low or increased creatinine, which is there in our patient. Anemia less than 11 HB is there. We have anemia and bone lesion, osteolytic punch out, osteolytic lesion. Have you heard of osteolytic lesion? Which can be seen on skull X-ray and spine X-ray commonly, right? So we have for everything. Our patient has a hypercalcemia, our patient has high creatinine, our patient has anemia, our patient has a spondylosis and bone pain and back pain. That's it. So what else you need, right? This is myeloma, right? So this is absolutely a myeloma. There are three entities. The most easiest entity, let me tell you in a very simpler way, conclude my talk for myeloma. MGUS, what is the difference? I will tell you. Smoldering, multiple myeloma, and multiple myeloma. The major difference here, less than 5% of plasma cell, no CRAB, calcium renal anemia bone. Is that clear, Dr. Aishwarya?
Yes, sir, it is.
Smoldering multiple myeloma, it could be more than 10 to 10%, no CRAB. Here more than 10% of the monoclonal plasma cell. Any one of CRAB, not all four required, any one. So if you have 10% plus anemia, diagnosed, done. That's it. This is the simplest form of understanding. Is that clear? Yes or no, everyone? Yes or no?
Yes.
Wonderful. So they may ask you smoldering multiple myeloma. So don't get confused. Myeloma means there should be a CRAB. That's it. So look for, when before you answering the myeloma in exam, look for CRAB. If CRAB is absent, then it is not myeloma. So there must be CRAB. Calcium renal anemia bone, shortly known as a CRAB criteria. That's it. So check your score now. If you wish, you can tell me, but at least check yourself. Question number 5. Are we going well?
Yes.
Yes.
Wonderful, wonderful. Stay tuned with me. Don't allow your brain to go for lunch and dinner. I'm also hungry. 62-year-old man attended the clinic with fatigue. His blood count shows WBC 2300, neutrophil 2%, hemoglobin 4.6. I missed the point, but it's 4.6. MCV is 102, platelet is 36,000, bone marrow aspirate and trephine show hypocellular picture with some lymphocyte, reticulin cells and plasma cells are also little seen. Some. What is the most appropriate treatment? So here again the problem, because we don't know the diagnosis. How do we jump to the treatment without diagnosis? So again my triad will not leave you. So in this question, first of all you make a diagnosis. They are directly jumping on the treatment. Investigation they had given you in terms of bone marrow, and bone marrow is hypocellular. They had given here. This is investigation. Aspirate and trephine show hypocellular. So investigation they have done, and they have done bone marrow, and they called as hypocellular bone marrow. Right. So you have the clue of hypocellular bone marrow. What's the diagnosis? What's the treatment? That's it. This is what the two questions from my side. Yes, Ajdani.
Yes, sir.
How are you? How is the weather in Maldives?
It's a very hot, sir. I'm good.
Wonderful. So let's discuss this. What do you think? What is the diagnosis and what point favors to your diagnosis? So first of all, tell me the diagnosis or possible diagnosis or differential.
Diagnosis is aplastic anemia, sir.
Aplastic anemia. You are very brilliant. Aplastic anemia. Now tell me what points, like myeloma, I tell you 10 points. Tell me here 5, 6
Yes, sir.
points.
Sir, here pancytopenia is there.
1 minute. I will write down so every other people also understand, because probably you are more brilliant, but we need to catch up with everyone. Okay, so point favor is what? Tell me. Number 1, aplastic anemia.
Yes, sir. Pancytopenia is there, sir.
Pancytopenia. Okay, what else?
And hypocellular bone marrow.
Hypocellular bone marrow. Yeah, that's it.
Sir.
I mean,
I
these are
found
the
out.
two common, right? So this is basically the only here little confusing is the. So let me tell you how the classical aplastic anemia present. Classical aplastic. So classical aplastic anemia. So male and female. So female is more common. It's considered to be autoimmune, and all autoimmune. If you don't know anything, autoimmune means female. All autoimmune, 9 out of 10 is female in general, whether it is a Sjogren or it is a SLE or autoimmune hemolytic anemia, autoimmune thrombocytopenia, autoimmune hepatitis, all female. Is that clear? So this is
Yes, sir.
considered aplastic autoimmune. So female more common. Common age group is 20 to 40. Here it's little, but it's not 100% 20 to 40, 90% of the patient present female in this age group, means 10% may present out of this range, right? This is classical. CBC initial test, low HB, low WBC, low platelet, that is called pancytopenia, right? Pan means all, cytopenia means cells counts are decreased. So pancytopenia. If you do, this is the initial test. Again, remember our 4-stage initial test. Diagnostic test is a bone marrow biopsy. Bone marrow, you see the hypocellular, hypo. So where is the hypercellular seen? Leukemia, hypercellular. Myelodysplastic syndrome, hypercellular. Myeloproliferative disease, hypercellular. So hypocellular is aplastic because cells are low. So if the bone marrow is not producing, obviously it is not coming in the blood. So this is low, this is low. Simple, no need to mug up, right? So this is a bone marrow biopsy, right? Hypocellular marrow. So this is classical. And now, so we diagnose the things. This is the aplastic anemia. So diagnosis is done. Investigation by bone marrow is done. Now jump to the treatment. So what do you think, Dr. Adani? What's the treatment of aplastic anemia?
Bone marrow transplantation, sir.
Excellent, but it is bone marrow
In this.
transplantation. So how you justify in this patient bone marrow transplantation, right, versus ATG? So PEG, GCSF, let me exclude one by one. So we will get close to the answer. GCSF, have you heard GCSF?
Yes,
Last
sir.
lecture I told granulocyte
Yes, sir.
colony stimulating factor. So 3 things.
Yes,
If you
sir.
want to increase HB, you give erythropoietin. If you want to increase WBC count, you give GCSF and platelet count, right? You can give either platelet, thrombopoietin, blah, blah, right? So these are the few things. So GCSF is mainly, so by increasing WBC, it's nothing because HB is also low, platelet is also low. So alone GCSF will not help. Oxymetholone, it's an earlier treatment, but not more sensitive and specific. Corticosteroid is treatment, but it is less sensitive and specific. So you have 2 options now. Antithymocyte globulin, it is also a treatment that is called shortly ATG, and bone marrow transplant. So what do you think? Which would be the close better answer? And why?
So if we
What
want
is
to
age?
increase all the cells, I think bone marrow will be good option, sir.
Okay. So you know the ATG versus BMT difference, where to give ATG, where to give BMT.
Not exactly, sir.
Fair enough. Anyone? Toprak, you have idea any?
Yes, it is important this case important age. If a patient is young, we should choose bone marrow transplantation, but he's 62 or bigger 50 age, we should give anti-thymocyte globulin.
Fair enough. Dr. Jinis, Dr. Jomoli Joy, any comment?
I think, sir, we cannot consider age alone. I think the plastic condition here is, see, neutrophil is only 2%, HB is 4. So I think I would go for a bone marrow.
Okay. Fair enough.
Or,
Not bad. Not,
um,
yeah. Anyone? Speak up.
there are no features of hemolysis or any combs suggestive of hemolysis, so thymocyte globulin will not be the right answer.
Okay, so you mean to say bone marrow transplant is the right answer?
Yes.
Okay, so what are the indication where you supposed to do the bone marrow transplant and where you not supposed to do the bone marrow transplant? Do you know?
Um, I'm not aware of the guidelines.
Fine, no, fair enough. That's okay. So this is the just for learning purpose. I make a slide. This is a normal bone marrow. So how the normal bone marrow looks like, right? So say for example, right? So these all are what I'm drawing. This is all cells. Can you see the cells? Red cells, white cell, probably this. And the white round is a fat globule. This white round is not cell, it is a fat globule. So here see lots of cellularity, right? Here lots of cellularity. This all what I'm drawing is all cell. This all cell completely. This is all cell. And can you see the same picture here? completely empty. Can you see it? This all
Yes.
white globule is
Yes,
replaced
sir.
by the fatty tissue or fat globule. So bone marrow is virtually replaced by the fatty globules. That's it. There is no hematopoietic stem cell, no generation of the RBC, WBC platelet, and that is why they have a pancytopenia and severe and significant pancytopenia. So treatment is what? Number one, remove the cause. So what are the causes, Dr. Ishwarya? Do you know what are the causes of aplastic anemia? Quickly.
This viral infections,
Great, wonderful. So one is viral infection.
parvovirus,
So viral infection, parvovirus. Even
chronic
more
steroid,
common than parvovirus. Do you know?
chronic, okay,
Hepatitis B and hepatitis C is a more common than parvo. You got it,
chronic steroid use can also lead to pancytopenia.
right? Even post malaria, many patients have these things. So there are two classification for aplastic anemia. One is idiopathic, where you cause the none, and one is secondary, or you can say primary or idiopathic, where cause is not known. Secondary is this all viral infections, right? So all viral, this parvo, hepatitis B, C, right? Many parasite infection. After that, bone marrow will uh, go under aplastic anemia, right? Then autoimmune disease, drug induced, like post chemotherapy commonest, right? Methotrexate, all immunosuppressant. These are the drug induced, right? So after giving the drug, right, methotrexate is very common because people are using for autoimmune disease. And I've seen few patients who dies of because of pancytopenia, and I did bone marrow that was severely aplastic anemia, and they died because of significant pancytopenia and agranulocytosis. So I think everybody is remembered agranulocytosis, yes or no?
Yes, sir.
Wonderful. So remove the cause. This is what the thing is. Remove the cause. So you must have to remove the cause, right? So you need to remove the cause. 1 minute. I'm sharing the slide again. Just wait 1 second. So this is not going. Let me open up the second PowerPoint. Is that clear so far? Yes or no?
Yes, sir.
Right. So this is the treatment. Remove the cause. So secondary cause, you remove it. Supportive treatment, red cell transfusion because HB low, platelet count transfusion. Why? Because platelet is low, especially in case of bleeding. Antibiotic, right? Because severe significant neutropenia, and you may give the growth support for increased WBC. Immunosuppressant, antithymocyte globulin and cyclosporin, stem cell transplantation as told for the younger patient, match sibling using reduced intensity. So this is an elderly patient, 60 years male, I think, if I'm not wrong. So this is the first option, especially considering this case is after 50 years, allogenic bone marrow transplant is more risky and high risk of mortality. So here you can try the first anti-thymocyte globulin. If no response, then you may consider the further treatment option for this patient, because 62 doing a bone marrow transplant is a risky affair in terms of mortality. Is that clear? Yes or no?
Yes, sir. Yes, sir.
Wonderful, wonderful, wonderful. 6 questions. So you check your score. I want you to check your scores. How many right out of 5?
Sir, just now joined.
No problem. So check your, I'll share the PowerPoint. Question number 6, 24-year of Kenyan student present to emergency department with fever and rigors on examination is found to have splenomegaly 10 centimeter below the costal margin. He has had several bouts of malaria in the past and takes anti-malarial prophylactic intermittently. The laboratory reports infection with the Plasmodium falciparum malaria. Anti-malarial treatment is commenced. but 2 days later he is acutely unwell with oliguria,
Hello, sir.
creatinine is high.
Cannot see the screen, sir.
Sorry,
Cannot see the screen. Question is not coming on the screen, sir.
let me check. Tell me yes or no.
Yes, sir. Now, okay.
Okay. So this is a case. 24-year-old Kenyan student present to emergency department with fever and rigors. He found to have a splenomegaly 10 centimeter below costal margin. He has several bouts of malaria with is on in the past and taking anti-malarial prophylaxis intermittently. The laboratory reports did Plasmodium falciparum malaria and anti-malarial treatment is commenced. 2 days later, he presented again with unwell oliguria, create high HB 4.5, rating is 25%. What is the likely diagnosis? Black water fever, drug-induced hemolysis, G6PD deficiency, sickle cell disorder, and tropical splenomegaly syndrome. Very, very, very tricky questions, but interesting. Very tricky, but interesting. Yes, Dr. Genius AP, any comment?
Sir, I think it's a G6PD deficiency.
So how do we know that this patient has a G6PD deficiency?
Maybe he has a several bout of malaria in the past and taken anti-malarial prophylaxis intermittently.
Okay.
That be one of the reasons.
So G6PD deficiency, what happens to anti-malarial drug when you give the G6PD deficient patient? Say for example, I'm G6PD deficient. I got a malaria and somebody told, sir, take anti-malarial. So what happens with anti-malarial and G6PD? Do you know?
Hemolysis, sir.
Which drug can cause hemolysis? Which all anti-malarial can cause?
Chloroquine.
Quinidine, chloroquine.
Okay, so this is homework, right? This is homework. Just try to gather these common questions in exam. So try to gather what is G6PD deficiency basically that you need to know, number one. And number two, drug can be avoided in G6PD deficiency. Very frequently asked questions, and especially the malaria and sulfur. Concentrate on to these things and tell me and post it in the group so we also learn. So G6PD is not the answer here. Yes, Azil, any comment?
Sir, no, what I thought is like usually uh, Africans have an predisposition to G6PD deficiency, which will get aggravated in case of certain infections.
Fine. Dr.
So I
Ishwarya.
thought G6PD, but also I know that people with G6PD deficiency are resistant to malaria.
Great.
So I'm not sure, sir.
Fair enough. This is an interesting
Drug
question.
induced
I think
Dr. Ikra?
black water fever.
Dr. Ikra, any comment? Dr. Ishwarya?
So this looks like a tropical splenomegaly syndrome.
But your answer is different.
Yes, what has happened is
So you changing the answer from A to tropical splenomegaly?
oh, I didn't see that as an option at all. Sorry.
Why you cannot see my screen?
No, I can see. I
Sorry,
yes.
you cannot see my complete slide?
I can.
Okay, so what's your answer?
This looks like a tropical splenomegaly syndrome, but when there has been this acute infection with the treatment, he has gone into renal compromise.
So what do you think? So it's a tropical splenomegaly or A or B or C. I
At
told you it's a
present, it
little
is
tricky.
black water fever. At present,
At
it is
present,
C.
wonderful. So keep your confidence high. It's a black water fever. It
Yes.
is black water fever. Not just. So let's see what is a black water fever. Black water fever is seen in falciparum malaria patients on inadequate treatment with quinine, right? So inadequate, intermittent, not taking, blah, blah. What happens? Development of anti-erythrocyte antibody. What happens? Massive sudden intravascular hemolysis occurs. Why? Because there is an anti-erythrocyte, means against RBC, the antibody develops in P. falciparum, those who are taking intermittent treatment or irregular treatment, right? And this is characterized by massive absorption. So what happens when there is intravascular breakdown of the RBC? There is a hemoglobinuria, simple. So there is a hemoglobinuria, and this excessive pigment in the urine, right, or excessive hemoglobinuria. First glass on the left side is a normal turbid urine, and right side is a black water fever, right, or black water. Water is a urine basically. So this is urine sample. So black urine, and that is why they are calling black water fever, right? So this is black water fever characterized by massive absorption of hemoglobin by the renal tubules leading to hemoglobinuria, because usually hemoglobin is not passed in the urine, RBCs are passed in the urine, right? RBC passed in the urine is called hematuria, and this is hemoglobinuria. So don't get confused between these two terms. Hematuria, because of renal stone, RBCs are passing in the urine. If you do the urine routine microscopy test, you find there is a 5, 10, 15, 20 or 50 RBC. That is a hematuria. And what is hemoglobinuria? When there is a free hemoglobin passed in the urine, you can measure it. It is called hemoglobinuria. So hemoglobinuria is different from hematuria. So clear your concept. Is that clear? So this is hemoglobinuria. Black water fever, massive intravascular hemolysis due to P. falciparum, which is the case, severe to acute hemolytic anemia. Hemoglobinuria, increased bilirubin. Why? Because there is a more hemolysis, more LDH, more indirect or indirect hyperbilirubinemia, and there is a ATN, acute tubular necrosis, because of hemoglobin cast. So hemoglobin is usually a not routine product or common product or no product in the urine which excretes, right? So this precipitated as a cast and which caused the acute tubular necrosis and renal failure or insufficiency. So this is what the thing is, and this is a classical picture. When there is a more hemolysis, hemoglobin will go down. Why? Because its hemoglobin is breaking fast, and in response to the hemolysis, there is a high retic count. It's a natural feedback mechanism. When hemolysis, bone marrow trying to produce more red blood cell to produce RBCs from the retic count. So higher retic count in any patient means there is some kind of hemolysis or hemorrhage is going inside the body. So when somebody give me a call, right, that's blah blah blah, this is the history, right? And if I'm suspecting the hemolysis or hemorrhage, I'll simply do the retic count. If repetic count is very high, I think that okay, there is something bleeding inside, intravascular or extravascular, inside the body or outside the body, somewhere bleeding, and that is why, because of bleeding and because of these things, retic bone marrow trying to produce more RBC, and that is why retic is high. That's it. So this is what the thing is. So you can't ignore the black water fever. So this is black water fever. This is another easy questions. 6 out of what score you considered? A patient with iron deficiency anemia is being started on treatment with oral ferrous sulfate. Which amongst the following earliest indicator of response to oral iron? Simple. You are a patient. You have a patient with iron deficiency anemia. You started some oral ferrous sulfate. That is a treatment or oral iron in short, right? Now they are what asking? Which amongst the following is the earliest indicator of response? So whether you started oral and how do you get to know whether the response of oral iron is there or not? That's the question. Increase hemoglobin, then okay, fine, because iron is working. That is why hemoglobin increase reticulocytosis, normalization of serum ferritin, or increase MCV. Tell me. Yes, Ajidani.
Yes, sir.
Why A?
Sir, it's a generally I'm telling, sir, I don't have exact idea, but whenever we are transfusing the blood and after 24 hour we are checking hemoglobin response, either it is increased or not.
No,
So
but that
just
is a
check
blood transfusion. This is not a blood transfusion. We are talking about oral iron. Blood transfusion is different. What they are asking, one patient has iron deficiency anemia. They started oral treatment with iron. Now, how do you know the response, which is earliest response, whether this response is coming or not? So, what are the tests among this list which tells you the earliest idea that okay, fine, whatever oral iron I'm giving, it's responding? That is the question.
in C, sir.
No, I think you are guessing. Anyone wants to try? Anyone wants to try? Aishwarya?
Sir, in iron deficiency anemia, there is what you can see in the smear is a pale RBCs, and whenever we are replacing iron with either oral or IV route, the peripheral RBCs get replenished with iron. So there is an increase in size of the cells and the color, and after that, the iron will get stored as ferritin. This is my understanding.
Okay, so what's the answer?
Increased MCV.
Increase MCV. This is your answer, Dr. Aishwarya, right?
Yes, sir.
Okay, fine. So in how many days, say for example, today is 28th of the April, hemoglobin is 7 gram. I started oral iron. So when the MCV, how many days after MCV will increase? 5 days, 10 days, 15 days, 20 days. When MCV will increase? You get my question, right?
Yes, I'm getting you.
When MCV will increase, another question when HB increase, another question when reticulocyte increase, and another question, four question when ferritin increase. That's all. Very interesting, isn't it? Let me tell you. Real story I'll tell you. So say for example here HB, here MCV, here reticulocyte count, and here ferritin. Right? So whenever you give oral iron, here hemoglobin 7, MCV 60, retic count 1%, and ferritin is, say, for example, 20, severe iron deficiency anemia. Is that clear, Aishwarya?
Yes, sir, yes.
After giving oral iron, the first thing will increase is the answer is a retic count. Within 3 to 4 days, it will start increasing within 3 days. It is peak at 7 days. So whenever I am treating any iron deficiency anemia patient, earliest response if I want to get to know, then what I'll do, after 7 days, I'll tell the patient and do the retic count. If the retic count is increased means what? Say for example, here RBC, red blood cells are low. That is why it's iron deficiency, hypochromic microcytic, right? But when you give the iron, lots of iron will be taken at the reticuloendothelial system within the bone marrow and very fastly producing the bone marrow and retic count increase. And retic count is eventually making the red blood cell. So this is mother, retic count is mother, and this is a baby, RBC is baby. Is that clear? From a retic count, red blood cell will generate. From megakaryocyte, platelet will generate. Is that clear? Yes or no? Right?
Yes.
So earliest response you can see in the retic count. This is number one, right? What is the number two? Number two, gradually when increase, once the RBCs are very well washed and very well filled up with the iron or oral iron, retic count, right, increase, that is earliest. After that, what it increase, right? They are gradually increasing the hemoglobin. Hemoglobin will increase. It takes roughly around 1 month. 1 gram of hemoglobin, 1 to 2 grams. So if you give oral iron 1 month, 7, it maximum it goes to 9 in 1 month. 1 to 2 gram. Third, once the RBC hemoglobin is improved, MCV overall size of the RBC will start improving. And lastly, the iron store. When you have hemoglobin of 14, say for example, within 4 months of oral iron, 7 to 14, you don't need to stop the treatment here. The biggest thing here people doesn't know is to replenish the iron store again you give at least 3 more months of oral iron to replenish the iron store. So again, this patient will not come with iron deficiency after few months. Our goal is not just to increase the hemoglobin. Our goal is to keep the ferritin more than 50. Is that clear? So if it takes 4 months to for more than 50, it's okay. You give 4 months, right? So our goal is not just to increase the hemoglobin. Our goal is to improve the iron deficiency as a store. So ferritin should also be increased. And ferritin 20, 30, 40, 50 means iron store is regaining. Iron store is again getting back to the normal, right? So once this iron ferritin normal, store normal, then you can stop the drug. So I will not stop the drug at 14 gram of hemoglobin. I'll become glad and happy that I'm good hematologist. My focus is to improve the ferritin as well. Otherwise, what happen if this will not improve? Then this 14, after say patient is a female patient, she is not eating well and menstruating heavily. Hemoglobin 10, hemoglobin 9, hemoglobin 7, right? Why? Because there is no store. But if there is a store, iron is keep continuously secreting from reticular as and when the needed, and hemoglobin will not drop. Why? Because there is a store. If you have money in the bank in crisis, it will helpful. But if you don't have money in the bank in crisis, you are helpless. Why? Because nothing, no store in the bank. So this is a bank. Ferritin is a bank. So you have to have a proper amount in the bank. So when there is a crisis, when there is a low hemoglobin, this bank will help you. That's it. Aishwarya, is that clear?
Yes, sir. Yes.
Got it. So answer is reticulocyte count. So now onwards, whenever you come across any iron deficiency anemia patient, and if you want to see the earliest response, 7 days or 10 days, you can ask the patient to come back. If you don't do hemoglobin, it's fine. Within 1 week, I'm not expecting much increase in the hemoglobin because RBC and all are getting settled down with the things. So this is a real chart. And before that, you can see the response within hours. But it is not a practical test. That is why within 12 to 24 hours, can you imagine? Within 12 hours of oral iron, time after iron administration, within 24 hours, replacement of intracellular iron, right? Subjective improvement and decrease irritability and increase appetite. Within 24 hours, you get a clinical improvement and there is a replacement of intracellular this symptomatic improvement, and within 36 means what, 1.5 day you can see the changes in bone marrow. What changes? Erythroid hyperplasia. So lots of RBCs are getting formed, but we are not going to do for bone marrow biopsy for iron deficiency. It's an invasive test, so not a good idea. But if at all you are doing, you can see earliest response in the bone marrow and then reticulocyte count. See, so reticulocyte count within 40 hours, mean 2 hours, maximum 3 days, and it will peak at the 7 days. So that is why we call the patient at 7 days. Okay, you come 7 days, we'll check it. And then hemoglobin, see the hemoglobin, and then the iron store, that is ferritin. So 1 to 3 months. HB, retic count. Is that clear? Yes or no? Yes or
Yes.
no?
Yes, sir.
All clear? Or any confusion? So that's it. This is what the story is. So I'm not going much in detail. So this is all regarding iron. Last couple of questions quickly. 2, 3. A patient with CKD, that is chronic kidney disease, found to have HB 8 gram per DL on investigation. Which amongst the following is the best possible treatment for him? Oral iron, blood transfusion, parenteral iron, erythropoietin. Very easy question, huh? So not going much in detail, all 100% correct answer, erythropoietin. Why? Because it is a chronic kidney disease. Chronic kidney disease or CKD or CRF, both are the same thing. Chronic kidney disease or chronic renal failure. Renal is equal to kidney. So both are the same thing, right? So chronic kidney disease, chronic renal failure, the 99% of the erythropoietin is a hormone. It's not enzyme. Erythropoietin is a hormone produced 99% in the kidneys, right? And 1% or so in extra renal compartment, mainly in the liver. So when there is a problem in the kidney, what happens? Erythropoietin is not producing. And what is the job of erythropoietin? When there is anemia, when there is a low hemoglobin, erythropoietin will stimulate the bone marrow to produce erythropoiesis. It stimulates erythropoiesis or to make a more red blood cell. But what happens when erythropoietin is not there? It will not stimulate the bone marrow to form the red blood cell. So there is anemia. So what is missing in a renal failure is erythropoietin. So you supplement the erythropoietin by iron, by transfusion, by oral. It is a temporary relief, but this is the main treatment of the cause. Erythropoietin is not there, so you replace with the erythropoietin. That's it. Any question? Any question?
No, sir.
Wonderful. Easy question. So don't think that Dr. Munjal is every time putting the toxic questions. Changes of megaloblastic anemia which may not be corrected by administering the folic acid alone. Hyperplasia of bone marrow, neurological changes, macrocytosis, or all of the above. Understand the question. The question is that you have a megaloblastic changes or megaloblastic anemia changes. So it could be B12 or it could be folate, which may not be corrected by administering just alone folic acid. What cannot be alone? So if you say for have a, both the deficiency, B12 and folate deficiency, and you are just supplementing the B12, folate, then what will not be improved? Which may not be corrected by administering just folic acid, and that is the neurological changes. So say for example, B12, right? Anemia is defined by MCV, normocytic, microcytic and macrocytic. Normocytic where 80 to 100 femtoliter is a normal MCV. Microcytic is less than 80 and macrocytic is more than 100. So macrocytic anemia, the biggest thing is the megaloblastic and the common cause is B12 and folate. So when you have B12 and folate deficiency, if you just supplement the folate, then neurological deficit will not increase with just folate, right? So neurological changes will not improve. Otherwise, hyperplasia of bone marrow will develop, macrocytosis, but neurological changes will not improve by the megaloblastic anemia. That's it. So this is the answer. Can anyone tell me in the house, whole house, all the names of B12? Wait 1 minute. I need only one volunteer. Name of B1, B2, B3, B4, B6, B9, B12. Any one volunteer tell me the name and deficiency. Say, I'll give you the clue. B1 is a thiamine. If the thiamine is deficient, what is the disease? B2, what is the name? B2 is
Riboflavin,
riboflavin. If deficient, what's the disease?
glossitis,
Eh?
cheilitis,
Cheilitis. And B1 is thiamine,
beriberi,
Berry.
beriberi. Again, there are wet and dry. We'll discuss later. B3 is
niacin,
niacin. Deficiency is what?
pellagra.
Pellagra. B4,
Does it exist?
sorry,
Does before exist?
sorry.
I don't know, sir. I've never heard of before.
Before you never heard before. Interesting. B6,
Pyridoxine,
pyridoxine. Pyridoxine. Deficiency,
Carnificin.
Neurological
okay. B9,
folic acid.
folate,
folic acid. Deficiency,
Megaloblastic anemia.
excellent. B12,
cyanocobalamin.
cyanocobalamin. Deficiency, megaloblastic anemia.
There is this B5 also, pantothenic acid.
Excellent. So many people doesn't know. So you should know, huh? Don't take it that, oh, this is a lollipop question, will not come in exam. So DHA is a tricky game. Anything can come. B1 is a thiamine, beriberi. B2 is a riboflavin, kilosis. B3 niacin, pellagra. B5 is a pantothenic acid, not B4, sorry, my mistake. B5 is a pantothenic acid. It's a burning foot syndrome. Pyridoxine is a peripheral neuropathy. So when you are giving INH, isoniazid AKT drug, we usually give pyridoxine, isn't it? Right? Because this is causing the peripheral neuropathy because of there is a deficiency of pyridoxine. So you are giving together. B9 is a B7 is a biotin. B7 is a biotin. So I have many patients, especially females, sir, hair loss is there. What to do? I usually advise them biotin. So take some vitamin which contains biotin. So hair fall will reduced. B9 and B12 megaloblastic anemia. Is that clear? Though it's a simple chart, but important. What do you think?
Yes, memorization is important every 3 years.
Yes, wonderful. Yeah, so we read it, but we probably cannot recollect it on one page. So I recollected on one page, right? B1, B2, B3, B5, B6, B7, B9, and B12. That's it. Next questions. A 20-year-old neonate has recent episode of jaundice with unconjugated hyperbilirubinemia. Peripheral smear shows increased reticulocytosis. There is a family history of anemia with jaundice. Which of the following is likely diagnosis? My triad: diagnosis, investigation, treatment. Sickle cell, beta thalassemia major, neonatal cholelithiasis, hereditary spherocytosis. And more questions below that. What is the likely diagnosis of this scenario? Base test and treatment. What is the gold standard test? Whatever the diagnosis is, that once you make a diagnosis, I will ask what is the gold standard test, and I will also ask few other questions. So your time starts now. I need a reason like black water fever. This is also little tricky. Yes. No one? Anyone? Yes, anyone? Otherwise, I will catch somebody. Sorry. I want someone who never answered me. Dr. Nadiba, any comment? You can unmute your mic and you can speak up, no problem. Dr. Naush, Mohammad Ishaq, Roshan, Dr. Saima, Suresh Kumar. So think that this question, if comes in exam, what will you take and why? Not just what will you take, why?
Presence of unconjugated hyperbilirubinemia is suggestive of enzyme deficiency. None of the options are consistent with enzyme deficiency. So that is where the trick lies.
Okay, so what do you think? What kind of this things is, because patient has a jaundice with unconjugated hyperbilirubinemia, and there is a increase the reticulocytosis count, and they are saying there is a family history of anemia and jaundice as well. So what do you think? Dr. Ahmadi, do you want to comment anything on this question? I would be happy to listen you.
No idea, sir.
So what do you think of? Say, for example, this question comes in your DHA exam. What will you think of? What could be the diagnosis or what could be the differential diagnosis? Na? You need to stretch your brain little bit, right? We don't need to mug up the things. If you mug up the things, you will forget easily. So I don't wish anyone. No problem. So think over it. Yes, Dr. Aishwarya.
Okay.
Why it is a neonatal things?
So the features, since it is hereditary and the presentation is in a neonate, this could be Gilbert's syndrome,
Gilbert's.
and that is the one leading to cholelithiasis and jaundice.
Gilbert, why?
Because
In
it is
so in Gilbert, so in Gilbert's is the diagnosis, no, basically. So here there is no Gilbert in the thing. So what will you select? Neonatal cholelithiasis, why it's developed? In 20 days of old patient cholelithiasis, I think, I mean, sorry, I'm not much pediatric expert. I'm hematologist, but I will ask Dr. Aarti, but I think to develop the stone, it takes some time. I mean, within 20 days, just neonate develop cholelithiasis looks little difficult. I will read again. Rather myself, I will read neonatal cholelithiasis. What exactly at what age it
It
will develop?
seems like hemolytic anemia.
So this is hemolytic anemia that is confirmed. Why? Because there is a hyperbilirubinemia is there, and another strongest indication is a reticulocyte count, as we discussed in the last quiz. So hemolysis, some hemolysis is there. So you can think or you can exclude one by one which hemolysis, why hemolysis, what hemolysis. So do you think
So
it is
it
a
can
sickle cell?
sickle cell, beta thalassemia, or hereditary spherocytosis.
Okay, so
So
now exclude one by one. Do you think this is sickle cell anemia? And if yes, then what are the point favoring the sickle cell anemia in this scenario?
um
Because you have to exclude as well, na?
yes,
Before,
sir.
yeah, this is the answer, but why this is not the answer? That is also important, na? And that is the main thing
Okay.
which we need to do while we are practicing MCQ at home. We don't need to just mug up the answer.
HBF
Yes,
is
sir.
there, so it will be protecting. So it's unlikely sickle cell.
Okay, so unlikely sickle cell. Beta thalassemia major, unlikely beta thalassemia, because beta thalassemia major, what happens? Right? So basically up to 6 to 9 months of age, there is a hemoglobin of HbF, right? So this fetal hemoglobin is up to 6 to 9. After when the baby is in the womb, in the uterus, there is a fetal hemoglobin. Once the baby got birth, up to 6 to 9 months, there is a major hemoglobin is hemoglobin F. I'll discuss one MCQ so you clarify everything. What is HbF? And after 9 months it switched to adult hemoglobin after birth, and before first birthday in 1 year they develop the significant anemia. So their diagnosis is usually taken after 6 to 9 months. It is a case of 20 days. So this thalassemia never diagnosed before the age of 6 to 9 months, because up to that it's a fetal hemoglobin. But right, but this is a physiologically, this fetal chain will convert into the adult chain, right, after 6 to 9 months of age. And what happens after 6 to 9 months? This fetal hemoglobin will not change to adult hemoglobin, and this gets hemolyzed and develop with the hemolytic anemia. So all thalassemic major patient present to the doctors with severe anemia and sometimes jaundice after 6 to 9 months of age or before first birthday. Here the 21 days, so it is less likely before 6 months. So major is not there. Sickle cell disease, there is a sickle cell anemia, right? So there is family history, but this patient doesn't mention the anemia, right? This patient doesn't develop. There is a family history of anemia and jaundice, right? So sickle again, this age is very very early for sickle, right? 20 days, right? Because again the fetal hemoglobin is also there. So fetal hemoglobin is a protective, right? And neonatal cholelithiasis, honestly speaking, I don't have much explanation about this. No, probably I'm not good in neonate, right? But I'll go and read it. But this is the not answer. This is a strong history of family history of anemia and jaundice, so something hereditary. So it's a hereditary spherocytosis. So this is the story. Hereditary spherocytosis is defect in the cytoskeleton of the RBC. What is cytoskeleton? So cyto means cell and skeletal means its physics, means skeletal. So let me draw you the cytoskeletal. So this is a normal cytoskeletal of normal RBC, and this is a hereditary spherocytosis RBC. So this is a change in a cytoskeleton of RBC. There is a protein on the membrane of the red blood cell. What is the What is that protein called as? Anyone? Credit question. Dr. Ishwari, any idea?
Microtubule, microfilament, these things are cytoskeleton, right, sir?
Right, but there is a specific name of the protein which makes this, sorry?
Spectrin and ankyrin.
Excellent, excellent. So this is a
Yes.
spectrin. This is a spectrin. So this is a red blood cell membrane, right? So this is a membrane of red blood cell, right? This is a membrane and this is a receptor, right? So if you see ankyrin and spectrin, right, glycophorin A, these are the protein, right, which makes this cell flexible. It's a flexible. What happens when this ankyrin and spectrins are not there, right? This flexibility is gone. So they converted, instead of by dumbbell shape, they become spherical. From dumbbell, they become a spherical, right? Because of this protein is not there, so flexibility is gone. And because of flexibility is gone, when they are passing through the tissue or structure, they are not flexible like the normal RBC, and they get hemolysis in the spleen, right? And this is why they present hereditary spherocytosis is a defect in the cytoskeleton of the red blood cell, leading to a abnormal round shape. So this is abnormal round shape. What I drawn you is abnormal round shape. This is not round shape. This is a dumbbell shape or biconcave shape. It is a normal. This is a round shape. So a round shape and loss of normal flexibility, as I told you, from biconcave to a oval. So when they are passing through the spleen, right? So this is spleen. There are lots of. So this biconcave, they can pass very easily, flexible. But what happens? They get stuck up in the splenic vessels and they get hemolyzed, and that is why they present three cardinal symptoms: chronic hemolysis, right? Because of this thing, jaundice. When there is hemolysis, there is jaundice, and spleen is doing lots of overtime, and that is why there is a splenomegaly. So splenomegaly is also there. What is the gold standard test? So gold standard test is a eosinophil maleimide flow cytometry test. Credit question in exam. Osmotic fragility is also there, but osmotic fragility is less sensitive and specific than this. So eosinophil maleimide flow cytometry test, right? It is a more sensitive and specific. Remember, little awkward name, eosinophil maleimide by flow cytometry is the most sensitive and specific. And treatment, when there is a hemolysis, there is a chronic folic acid deficiency, so you supplement the folic acid. In severe anemia, you give blood transfusion by RBC, and in extremes or moderate to severe anemia, you do the splenectomy, and by doing the splenectomy, you are stopping the hemolysis, so patient may not be transfusion dependent. So I treated few patients of HS, hereditary spherocytosis, where we did the splenectomy because they are presenting with severe anemia, gallstone, jaundice, right, and massive splenomegaly. So this is the pathophysiology. And last but not the least, before the start of the round, I think we discussed this question in the last thing, so I don't want to go again. Easy questions. And which one of the following organism can cause infection following the splenectomy? So you did a splenectomy of the patient. Which of the following organism can cause infection following splenectomy? So, sorry. Yes. So E. coli, Klebsiella, Pneumococcus, Pseudomonas. Yes, volunteers. Anyone can tell me?
Post splenectomy, we become vulnerable to pneumococcal, meningococcal, and H influenza, sir.
Great,
All the
wonderful.
capsulated.
So capsulated organism, so pneumococcal, meningococcal, and H influenzae, right? So here the given pneumococcal, so we'll go for pneumococcal. And before splenectomy, especially in a plant case, you have to give 3 all vaccines: pneumococcal, meningococcal, and H influenza vaccine available. So you can give that vaccine, and in case of emergency splenectomy, maybe trauma, rupture, road traffic accident, rupture of tropical splenomegaly, rupture by trauma, injury, gunshot, stabbing. By any case, the spleen is ruptured and you want to remove in emergency. In that case, you can give this all vaccine after 2 to 3 weeks of post-splenectomy as well. So pre and post, both the way you can see. So these are the organism, as you rightly told, doctor, right? So these are the organism, encapsulated organism, as I told you. So encapsulated organism, the protection, streptococcal, Streptococcus pneumoniae, Meningococcus H influenza, also gram-negative rods. It also increase the risk of this other as well, parasitic infection, malaria, and babesiosis. So this is the very frequent, easy questions, but you should keep in mind that what organism can cause what things. Last questions for today. Is it okay? Last question with you. Very important questions. Very. It will completely clarify all your hemoglobinopathies concept and clarity. Is that okay with you?
Okay.
Great. A 21-year-old male patient with severe anemia, HB5, he gives a history of similar presentation 3 years back, which was adequately managed with single blood transfusion. He has not required any further blood transfusion till date, most likely diagnosis. Thalassemia major, thalassemia minor, thalassemia intermedia, autoimmune hemolytic anemia. Last questions for today, genuinely. Yes, push hard. Last questions. Yes, Sarin, Dr. Sarin Kuryaske. Dr. Sarin.
Yes, sir.
Yes, tell me, sir, what's your explanation?
I think it cannot be thalassemia major since he required only one transfusion and otherwise he's okay.
Wonderful. Good concept, very good concept. So major is gone. Then, and again I told you major is usually at the first birthday. It is a 21st birthday because 21-year-old now. And now is required transfusion. So obviously major is not there. Rather, they may not live up to 20 years in many patients. In many developing countries, they die at age of 20 because of transfusion overload. I mean, iron overload. Yes.
Thalassemia minor is asymptomatic due to, I think it is thalassemia intermedia.
Great, wonderful. So it is thalassemia intermedia. Why? See, now we dissect this question just to understand. Let me tell you the difference. Thalassemia minor, thalassemia intermedia, and thalassemia major. Thalassemia minor is a minor genetic defect. So let me tell you first, basic thing first. In normal adult hemoglobin, this is the ratio HbA, HbA2, and HbF. In normal, it is around 98%, 95 to 98. This is around 2 to 3%, and this is less than 2%. This is normal. So if somebody does my hemoglobin electrophoresis and find, right, and in HbS, this is called HbS, sickle is 0. Sickle is 0. Sickle is 0, right? And let me put last thing is a sickle cell disease, fourth one. So it's all clear. So this is normal, right? What happens in thalassemia minor? The only defect in thalassemia minor is increase in the HbA2. HbA2. This HbA2 becomes, instead of 3%, it goes to 5, max 10%. The rest of the things are okay as per the normal. So just there is a minor defect. The adult hemoglobin is fine. It could be around 90, 95%. So not a problem. Just 5, 10%. Instead of 2 to 3%, this minor hemoglobin is increased, right? And this is what it shows in a hemoglobin electrophoresis. This all three things will be done on hemoglobin electrophoresis. So any hemoglobinopathies, any abnormal hemoglobin you want to find out, you need to do one test called as a hemoglobin electrophoresis. What is that? This is a slide, or this is the things. They apply the electrode here, plus minus, right? And they see where is the thickness on the band at HB A2, F, S or other, where the thickness and band is seen. I'll show you the picture, don't worry, just for your understanding, right? So hemoglobin A2 is increased, that's it. It is a minor defect. Patient is asymptomatic, doesn't require blood transfusion. That patient required blood transfusion. Go back. This patient has a 5 HB, so HB is never a 5. Again, let me tell you, if the thalassemia is there, then how is the hemoglobin, right? So when there is a thalassemia, right? Right. So here, if I can, 1 second, you can ask questions later on, no problem. Here, hemoglobin usually never less than 9. So thalassemia minor, whenever you come across thalassemia minor, what the critical things you have to see? What is the hemoglobin, what is the history of blood transfusion, and what is the A2. That's it. Three things you have to see. There is no blood transfusion, HB is usually more than 9, and A2 is increased. It is thalassemia minor. That's it. Simple. Thalassemia major, usually diagnosed at 1 year of age. This patient is at 20 years of age, because at 1 year of age, he usually present with 5, 6, 7 HB. Transfusion dependent. It will not develop because hemoglobinopathies is a congenital, inherited. Mother is minor, father is minor, baby develop major. So major is since birth, right? So at the age of 1 year, he developed with the 5 HB. So he diagnosed in early age, not at the 20 years of age. Here, what's the problem? So this is, you understand, this is a thalassemia minor. In a major, what happens? I told you already, 6 to 9 months of age, the main hemoglobin is HbF, and after 9 months it convert into HbA. But this conversion will not happen, so HbF will persist even after 1 year of age, right? And that is the biggest problem, and that is a major. And in major, instead of less than 2% in adult, this F is more than 90% in adult, and that is thalassemia major. And instead of less than 2% at 1 year of age, you can see 90% of the hemoglobin F is persistent at the age of 1 year, and that is thalassemia major. That's it. This is what you need to remember. They are very much symptomatic because they present with a severe anemia. That is why the name comes major. Usually hemoglobin is 5, 6, 7. They are transfusion dependent anemia. Transfusion, every month they have to transfuse the blood, right? And they are quite symptomatic. So here HB is less than 5, 6 or 7, right? 5, 6 around hemoglobin. HbF is increased. They are symptomatic. That's it on hemoglobin. And intermediate is the entity between this. They are not transfusion dependent. Transfusion is required intermittently every 1 year or 2 year or 3 year. They are mildly symptomatic, right? Mildly symptomatic. Here the HbF is high, but it is not 90%, usually less than 50%. That's it. This is what the diagram is. Again, back to the last slide. This is the normal adult. If you remember this, you never had any problem in hemoglobinopathies. No need to mug up at all. We are doing mug up. Don't need mug up, right? So this is HbA, that is adult hemoglobin. HbA2 is a minor, and HbF. HbS is not present in adult hemoglobin, that is why it is a 0. And this is a normal. So what is a normal? HbA is a major, 97%, F is 1 to 2%, A2 is 1 to 3%. As I told you, sickle cell trait, what it increased trait, this is sickle going on, no problem. So what happens in thalassemia minor? I add 2 column. In thalassemia minor, what increase? A2 will increase, rest of the things are same. In thalassemia major, F is increase, rest of the things are normal. And sickle cell trait and sickle cell major, sickle cell trait like thalassemia, or you can say sickle cell minor and sickle cell major. Major is a disease and minor is trait. Like Thalassemia trait is equal to thalassemia minor. So don't get confused. Trait means minor. So sickle cell minor, less than 40% of hemoglobin S and more than 40% is sickle cell disease. Sickle cell trait, sickle cell disease. That's it. That's it. This is complete hemoglobinopathies. But the beauty is what? You must know the normal hemoglobin electrophoresis. If you understand the normal hemoglobin electrophoresis, so whenever you are giving answer to any questions of hemoglobin and you are giving the answer thalassemia minor, so one thing it strikes to your mind, what happens to A2? If it is A2 is normal, then forget about thalassemia minor. If you are diagnosing thalassemia major, think of HbF. Think of HbF. Is it HbF? It is very high, more than 90%. If it is not, forget about thal major. If you are thinking about sickle cell and sickle is 0, forget about sickle cell because HbS is 0. So 0 is a normal 0. But if it is less than 40% HbS, it is a minor. Simple definition, more than 40% is a major or disease. That's all. That's it from my side. Thank you very much. Is that clear?
Thank you.
Is that clear?
Yeah.
Wonderful. So I will share this chart. So now
Yes,
it's just very quick session for 5 minutes or less than that. The feedback. Dr. Aishwarya, is it your first class?
Yes, sir, this is my first
Wonderful, wonderful. So we usually take some feedback from the new students who join. So how was your experience? How is the learning quality, content, and up to the mark? What's your experience?
I am very happy to have my 2 hours given to such nice learning. It was like brushing up all the basics, applying logic, applying the old knowledge to new concepts. So I'm very happy to be a part of this section.
Excellent, wonderful. Thank you for your feedback. Probably it motivates me. That is why we are taking. Yes, great, wonderful. So you learned, and something unique you learn, something unique.
Yes, what I learned is though I am a specialist, I am not perfect. I need to read and keep updating myself. So,
No problem. Our coach
continuous
are all
process of
excellent.
learning.
So we have a good coach. I mean, there are a lot of people in coaching as well, regular. So this is one mock test I'm taking, but my other coach are also brilliant. So they will give you the different ideas of different subjects. I'm not good in gynec and pedia. So they will take gynecologist will take gynec lecture, pediatrician will take pedia lectures. So I'm morely into the internal medicine and hematology. So probably you will enjoy with me hemato and onco. So onco is coming back to back. Next couple of weeks would be onco.
Okay.
Fair enough. So you enjoyed. That is a great part. Anybody else? Volunteer? Anybody? Any comment? Anyone? At least just to respect me. Any comment?
So this is my first class.
Who is this?
Yeah, I'm Dr. Saumi.
Yeah, Dr. Swami. Great. I would like to hear from you. First class. How was your experience?
I've
First day,
attended
first show.
yes, yes. I've joined other group and I've attended class, but I felt your class is more useful and more informative.
Okay, great. Wonderful. Wonderful. So did you learn something today new in
Yes,
hematology?
I am actually, the others are much young doctors here. I have had a good gap in practice. So I'm re-entering into practice. So everything seems like new for me. That's how I felt that this class is useful.
We will make you from new to old. Don't worry. Great. We have good players in the team. Yes, anyone else? Christiana, I think you are also attending. Christiana Ramos. Any word? I think Christiana joining from Philippines. Christiana, are you there? Okay, probably she is cooking. I don't know. Yes, Dr. Onkar. Anyway, you are joining. Dr. Onkar, are you there? Dr. Grasel. Dr. Ikra. Dr. Ajdani.
Yes, sir.
Just conclude the session. So we'll pack up.
Sir, this session, I was not here since the beginning, but I
Right.
joined in the middle, sir. But it was very informative and lots of new things I learned, which was I never listened before. Those kind of things, and it's a very informative session, sir. Thank
Great.
you very,
So we
very
will.
much for this great informative session, sir.
Thank you very much, brother. You motivate me every time. Yes, doctor. Lastly, Nadiba. Nadiba, Naush, Nishant. Anyone? Last comment. And if you shy to do the comment here, you can comment in the group as well. Yes, Toprak. Lastly, how was the learning today, Toprak? Are you there, Toprak? Fine, fair enough. No problem. No worries. Thank you very much, everyone, for joining and listening me coolly and calmly. I tried my level best to make the thing simplified and easy to understand. And we'll see you again next week with another oncology. I guess we'll switch to hemat on in between other coach will guide you for other subjects. So thank you very much. Keep in touch. Do let me know for any help, guidance, suggestions, or mentoring from our side. We are happy to help you out. Thank you very much, and I'll share the PowerPoint with you guys in next couple of hours. Thank you very much, and enjoy your Sunday. Thank you.